So I want to thank everyone for coming back. And for anyone who's new, welcome to our meeting. So we're looking for restaurant recommendations. So, please write that down on your evaluations so we know where to go next time we're in Nashville. I want to, again, welcome you to the NIWHC Annual Forum. We had a very long and successful program yesterday, very exciting. We have over 200 people who are participating in this conference. We have about 40 online, and then we have about 160 who participate in the room. I know a lot of us have been looking forward to meeting friends and colleagues we've seen only virtually, and it's hard to get dressed again. I had to find how to retie a tie again. I have to learn that. I don't know, I may have told some of you the story that the first meeting we had after the height of Zoom was we had two speakers come on up and they had their coats and ties. And then when they walked away, they had their shorts and flip flops and t-shirts on because they weren't used to talking in a Zoom, in a live video call. At any rate, so today's program, we're going to drill down in a lot of areas. So if you take a look at the agenda, we'll be starting out with talking about the key legislative and legal issues impacting worksite health centers. And again, I remind you, we're taking a line in the sand. We don't call these clinics anymore unless you're only doing first aid and triage. These are health centers. And then we'll be talking about how to expand pharmacy services and what are the trends and innovations that are taking place. We'll have a networking break, and at that break, it'll be your last opportunity to complete the bingo card for the door prizes. Please do visit all the booths and exhibits. And we'll be pulling the drawing, and you have to be here to win. And that'll be at the very end of the program at 12:30. So I hope you'll be able to stay. We'll then have a session on virtual services. We'll talk about measuring and benchmarking, which is key. And we'll close in by how to accelerate utilization in your worksite health centers. So a very full day. And again, I hope you'll enjoy it. So starting out, I have three of my closest contacts, colleagues, and representatives for us. Leading the effort, we've got Stephanie Eckerly, a partner with Craig DeVault, secretary of the NAWHC board, who will be moderating the panel. And she's been our internal and external legal expert for our organization. With her is James Gelfand, James's current title is Executive Vice President of ERISA. We won't talk about any future titles at this point. ERISA, the ERISA Industry Committee, or ERIC, which is our key legislative partner, and he'll be talking about not only what's going on in Congress relating to health benefits and worksite centers, but give you an update on our Fair Market Value Collaborative, I talked about briefly yesterday. And finally, we're pleased to have Will Wright, who's the General Counsel for Premise Health, who'll give you an insight of what an in-house counsel from a worksite health center partner is trying to deal with and all that. So with that, please welcome our panel for this morning. Lastly, again, if you want to have questions, you can text me at 847-606-5527, and we'll ask those questions toward the end of the session. Thank you very much.
Great. Thank you, Larry. And thanks everyone for joining us at 8:30 for legal and legislative topics. So it's a great one to put first. I'm Stephanie, and usually I give this presentation. So I'm super excited today to be moderating the presentation and have Will and James with me. So we're going to start off today with James. If you could talk about what you're seeing in DC, the legislative landscape right now, I think that'd be really helpful, just as kind of a broad overview.
Sure. Thanks, Stephanie. And I think legislation is the most exciting thing. So this is the right thing to start off with in the morning. You may have probably heard throughout the last year or so that September was going to be a big month in Washington, D.C., and there was going to be a lot of action. And it turns out that was just a complete falsehood. And instead, what you're seeing is that Congress is doing their best to focus on campaigning for the November election and to prevent a government shutdown. So Congress does have to take action before September 30th, or there will be a government shutdown. My prediction, they will take action, but it will be very uninteresting action. They will basically sign a continuing resolution that says the government will continue operating exactly as it has been operating until the middle of December. So we will just defer our crisis for another couple months. One thing that may be added to that bill that is, somewhat interesting, exciting, are some provisions related to the Food and Drug Administration. Because if they don't reauthorize the ability of the FDA to collect fees from drug companies and medical device companies, FDA is going to have to start laying off staff in the next couple of weeks. And it's unlikely that Congress will allow that to happen. But you may also be aware that there's a huge amount of controversy over exactly how they allow FDA to continue right now. The Senate has invented a completely new regulatory regime for cosmetic products and for dietary supplements and for lab developed tests. And the House says, we're just not interested in that. And so they're having a big fight between each other, and all the people who work at the FDA are freaking out. But that's what we're expecting for the next month is they're just going to talk about that, work on that, and then they're all going to go home, right? And they won't work throughout the month of October because they'll be campaigning, and then there'll be an election in November, and somebody, we don't know which side, but somebody's going to be deeply depressed and not want to come back to DC for a couple of weeks. But then they'll come back in December. At the end of the year, there will be some kind of a lame duck session, not necessarily because they want to, but because they'll have to, because they forgot to fund the government for the other 2 weeks in the year. And also because there's a whole number of other things that need to get done. And actually, I think I have a slide up here that just lays out some of the sort of things that they just forgot to finish, right? That they were working on and they promised to get done this year, and they didn't, right? But they will, I think. So what you may end up seeing is at the very end of the year, and I'm talking like literally the night before Christmas usually is a good time to get something like this done, because members of Congress are just so annoyed that they won't be able to be with their family that they're just like, fine, I'll vote yes, right? Whatever it takes to get me home tonight. We'll see a massive piece of legislation, thousands and thousands of pages with hundreds of different policies that not only funds the government through sometime probably in the first quarter of 2023, but has all kinds of interesting stuff in there, from changes to the way prescription drugs are regulated, to mental health changes, to tax changes and regulatory changes that haven't been even talked about, potentially something on pharmacy benefit managers, potentially something on patient safety, just a whole skew of things that really didn't get talked about quite a bit, and hopefully maybe something on fair market value too.
So speaking of fair market value, nice lead in there, James. Eric has been really instrumental in working with National Association of Worksite Health Centers on FMV issues. So could you give everyone a little overview of what you're doing and why it's important? And I'd love to hear from you, Will, too, after that, on Premise Health's position on the FMV issue.
And I'm assuming that everybody in this room is familiar with the challenge here, right? So I represent employers, about 100 of the nation's very largest employers who all have big self-insured plans. Most of them have both a PPO and a high deductible health plan option. Many of them have on-site health centers. Not going to say clinics, really. So obviously, if you're enrolled in the PPO, they usually waive the costs or charge a very minimal copay to get people, to incentivize them to use the health center. But of course, because of IRS rules, if you're enrolled in the high deductible health plan, you have to pay the entirety of the cost of the care that you receive up until you've paid through your deductible. A lot of people throughout the year never pay through their deductible. In fact, a lot of people don't even have enough money in a bank account to pay their deductible, even if they wanted to. So we are working with NAWIC to try to change that rule and to say, if an employer wants to pay for somebody to go to the health center in order to incentivize them to go to a place where we know they're going to get superior care, it's going to be high value care, and we're going to be able to make sure that it's integrated, it's coordinated with their health records and their care team, et cetera, we should be allowed to do that, right? We shouldn't force the patient to pay. And we've been working with the Fair Market Value Collaborative for quite some time to figure out, first of all, how do you do that, right? There was a proposal to do that was first drafted in 2005. Now, if you think about what worksite health centers looked like in 2005 versus what they look like today, the difference is vast, right? So if we were to take that legislation that was written in 2005 and pass it, it really wouldn't do a whole lot for you, right? It'd be fine if you basically have a nurse in a closet who's doing that kind of care. But if you're doing things like mental health, if you are dispensing products through a food pharmacy, et cetera, it wouldn't have covered any of that. So we spent months basically working through figuring out how exactly do you write this in a way that meets the needs that the patients and that the providers have today? And I think we got it right. I think we got there. Next, though, we had to find people in Congress who would be willing to take on this for us and to be the leads. And we got really, really great members of Congress to be the lead. A Democrat and a Republican in the House who are both on the committee that's going to get to make the decision of whether or not to move things forward, the House Ways and Means Committee, as well as some other members who agreed to sign on and say, we will put our names on this and say, this is important. So we've got this legislation. It's new, it's interesting, and it's moving forward. More members of Congress are getting interested in it. And now what we have to try to do is get it across the finish line. So one of the first things that we're going to try to do is to figure out, what would it mean for the federal budget if this was to pass into law? Like, would it increase the deficit? And if so, how much? Because we need to know that so that we can get into the mix for that December legislative package.
So Premise has been working sort of independently. This issue's come up. It's a perennial favorite. There was a bill in 2018 that passed the House, and then it went to the Senate to die. They couldn't get any additional action on it at that time. But that bill was much broader, included a lot more community-based clinics instead of sort of dedicated health centers. So I think the way that we've come together in this effort is much more focused. It much more articulates the value and the value proposition for worksite health centers. And so to James's point, we have a couple of, bipartisan support. Now, if we can expand that, including more House Ways and Means members, then we feel like we have a better shot of getting it through the House. If we get to full House, I think we have a reasonable shot. The corollary to this is the telehealth, and we can, during the pandemic, there was a policy acknowledgement that removing the barriers to receiving primary care is a good thing, particularly because of the pandemic. There was a carve out that said you could receive a virtual health visit without offending the IRS requirement of paying a fair market value for that encounter, regardless if you're in an HSA, HDHP plan or not. So there is this acknowledgement, this intuitive gestalt in Washington that it's okay to allow people to get more primary care. This is not driving utilization in a bad way. It's driving utilization in a good way. And so there's a separate and parallel track that there is still a current exemption for reduced value or reduced payments for telehealth visits that is tied to the declaration of the public health emergency, currently set to expire October 15th or so.
Well, but this provision, I think, expires New Year's Eve, right?
It goes 120 days after, something like that. So we're going to get end of year. There's going to be another scramble where people have been able to access virtual care through one of our operators or through some other mechanism that's suddenly going to be taken away. So there's some real things at stake. There's some real changes that's currently behaviors are incentivized with this economic incentive that probably won't be there after the first of the year. And so usually they don't like to take away these sort of things. So we're trying to push this forward. You can come up to either of us after. The call to action is to, if you have any relationships with representatives in the House, to try to use any influence you can to help this go through. 7487, House Bill 7487. I've got handouts.
Perfect. Thank you. James, can you give us just and I know we have kind of a short amount of time here, so a quick overview. What do you expect for the next session and from a 2023, maybe what are kind of the top three things you're seeing that is going to matter to this group right here?
Yeah, I mean, I think one of the most interesting things, and I know if you asked me 2 weeks ago, I might have said, oh, Republicans are definitely going to be in control of the House of Representatives and they're going to do all these different things. Today, complete toss up. So I don't know. But let's say that Republicans do take control. One of the issues that they are the most comfortable with in the healthcare space is dealing with health savings accounts. And because of the issues that we're focused on, both relating to telehealth and to primary care and to the worksite health centers, are very focused on those high deductible health plans. That creates a massive opening for us to put forward policy that's already been vetted, that's been worked on by experts, et cetera, that's not going to take a long sort of runway to get to, ready for prime time areas. So I would put that as a very top thing to focus on there. They had also put out a number of sort of policy papers through this group they created called the Healthy Futures Task Force that kind of said, like, if the Republicans take over, here's all the stuff we're going to work on. And if you and it's like very cryptic. It's a series of one pagers. But if you parse it out, one of the things that they did pull out of there was talking about middlemen in the healthcare industry. And I think that they were looking at PBM in that space. So that's one that I would expect they take on, especially considering that, you know, the Republicans were against the stuff that the Democrats did on prescription drugs. And so they're looking for a way to kind of do their own thing and say, well, we did something solid for the folks who kind of got dinged before. And if the PBMs and the pharma folks are at odds, then they can go after the PBMs and say to the pharma folks, we just did you a solid. Please keep donating. Another thing that's most likely going to get done next year will be something else related to telehealth. They're going to do something very short, I think, at the end of the year, but because like Will said, they don't like to take benefits away from people, but there are a whole bunch of different policies, mostly in Medicare, but a couple that are in the private sector that will expire when the public health emergency ends, which I do believe someday it has to actually end. And when that happens, they're going to want to keep the gains that have been made. There's a lot of concerns about like fraud in telehealth. There was, you know, at the beginning of the pandemic, there was this huge concern like, well, if telehealth is free, grandma's just going to call the doctor every day because she wants somebody to talk to. I don't think the numbers have borne that out. Right. I think that it's kind of been proven that telehealth did not create waste, fraud, and abuse, and that it did improve people's health and improve their access. So I think that's going to be top of the list as well.
Yeah. The counter to that in the policy is there's been a few maybe not totally great operators in telehealth space, in the mental behavioral health space, that have been liberal with their prescribing practices. And so, you know, it's like the original era of internet pharmacies, where you just kind of click through and you got a controlled substance in the mail. So there's going to be some instinct to pull back on some of those things. That see what this spawn, all this innovation, it spawned some bad operators, but it always will.
So I'm going to switch gears here. So I'm from Indiana, and of course we had Roe versus Wade overturned. And this is something Will and I have been talking about, you know, at least for our healthcare providers, it's top of mind with the position that our Attorney General is taking now, and the new law that was just passed. And so, of course, hospitals, OBGYN groups, you know, ACOG, they are all concerned about this, but we're starting to get a lot of questions from worksite health centers too, as far as especially providing OBGYN care, state licensure issues. And so I'd like to know, how is this impacting Premise, and, you know, what are you having to do in light of the different state laws now you're seeing on the abortion issue?
Yeah, I mean, it's disruptive and not in a good way. And beyond the substance or the politics of the core issue, the governmental structures are causing havoc in the way that we have practiced medicine for, you know, a long time. So from a corporate perspective, it's relatively settled about how to set up a professional corporation with a physician and how to look at each state and operate. But when you take states like Texas, you know, I'm sorry if anybody's from Texas, you know, the problem is not that there are jurisdictional boundaries within Texas about what you can and can't do in Texas. Everybody agrees they can do whatever they want. If you're in Texas, they can restrict your practice abilities. But some of the laws that haven't been challenged yet, but probably will be, but nobody wants to be the test case, right? I don't want to spend my money or our money or your money on challenging Texas's overreach for an individual that doesn't live in Texas that does something outside of Texas. So in a virtual health world, if you've got a California licensed doctor who's also licensed in Texas, who sees a California patient, and they're all in California, but Texas somehow doesn't like the result of that encounter, they'll go after that doctor's license in Texas. And if you know much about, you know, interstate licensure, it's a domino effect. Once you get one disciplinary action on one license, you got to report it to every other license you have, and it becomes it's very untenable if all these different states are going to take action based on one state. So it confounds the ability to operate efficiently. It scares clinicians. I think they're nervous about engaging in interstate practice if they have a license in a jurisdiction that's more restrictive, Indiana or otherwise. And so it creates uncertainty, right? Markets hate uncertainty. I don't like uncertainty as trying to advise clients, my main client, my only client as Premise, to make sure that we have the infrastructure, the policies, and the workflows in place so that they're protected.
Are you seeing this impact, or have you had discussions with employers? I see employers struggling with, can they pay for an employee to go to a different state to get, abortion care that they need and medically urgent situations? Are you having employers ask you guys questions about this, or are you kind of on the outside of that?
We're more on the outside. But I mean, there's one, I think it's, one of the Carolinas, I won't say which one. They have a restriction on what you can publish on a website. And if you purport to publish a directory that aids and abets someone leaving the state to go to another state to seek those services, then you can be held liable under the way their law is written. Again, it feels blatantly unconstitutional under the Commerce Clause, which everything gets fit under the Commerce Clause, where a state can't pass a law that interferes with state, commerce among the states. Well, someone traveling out of state for some service that's legal in that state feels like it's really offending that Commerce Clause. But again, nobody's challenged it from the provider perspective. But it makes us second guess everything that we publish, everything that we're listing as a scope of services. We have to go through that analysis, and it's not easy, and there's not a great answer either way.
What are you seeing from
And I was telling Will earlier, we get a lot of calls. What exactly is aiding and abetting?
Right.
And how do you determine whether a statute is a generally applicable criminal statute or whether it is governing an interstate benefits plan that is governed by the Employee Retirement Income Security Act? And the answer to both of those questions is, gee, I'd love to know. But we have many employers that have proactively made changes to their benefits in the wake of the Dobbs decision, right? Whether that is doubling down on telehealth and mail order pharmacy, whether that is creating a travel benefit that didn't exist before or expanding an existing travel benefit, or whether that is simply creating a new relocation benefit for employees who just don't want to live in Oklahoma anymore, right? Or Texas, et cetera. And what you're starting to see is the legislators writing letters to my companies. So Fortune 100 companies, their HR departments are getting letters from legislators and from sort of outside sort of agitator groups that assist the legislators. And they're saying things like, dear, company X, thank you for telling us how you are getting around Texas's abortion ban. Now we know what we need to ban in the next session. We would advise you not to get rid of any of your emails, text messages, or meeting notes. And we would advise you that if any of your executives will be visiting Texas in the near term, to expect a visit. This is creating a really chilling effect on the employers, and they're very much worried. But at the same time, I think you guys know that by now, the employers have to be responsive to the employees, right? They have to be responsive. They are getting a massive amount of pressure from the employees to do something proactive, to help in some way. And so they're kind of stuck between a rock and a hard place.
Including some very large private law firms have received those notes too. So.
Yeah, no, it's a hot topic. I feel like daily we're dealing with it. So we're going to stay on hot topics right now instead of just the usual. Let's talk about the recreational use of marijuana.
Woohoo.
And how that's been legalized in some states, and how Premise Health, and I want to hear about it, what you're seeing too, is handling that from a pre-employment drug testing standpoint. And not just pre-employment too, for employees that are in, jobs that require certain safety requirements, but they also, have states that allow this. So is Premise Health dealing with this? Are you seeing
Sure.
these issues?
But both from an employer perspective and as a provider. So if anybody went out downtown last night, you smell it. You can't avoid it. It's like it's a skunk farm down there. So the bell has been rung, and I don't think it can be unrung at this point. So from a jurisdictional patchwork, again, uncertainty, New York City has a certain approach to drug testing. The state has a different one. Pennsylvania has something different than the city of Pennsylvania. And so you have these different jurisdictions that approach it differently. For these recreational states, and there's New Jersey, Connecticut, Montana, there's a handful that are very smart. They're very savvy, right? The pitch to the legislatures was pass marijuana, we tax it and move on. We tax and regulate. And by the way, here's the number that you can expect added to the coffers. And so by prohibiting employers from testing for THC, they've provided assurance to the marketplace. Don't worry about your job. We got you. Not only can you buy, consume, and use, you can't be punished for it. A private employer cannot punish you for having a hot drug test. Now, some of them have general carve-outs for safety-sensitive positions, and DOT it overrides all those state ones. But a couple of them don't have a carve-out for medical personnel. So you're stuck where you can't test in those certain jurisdictions. So we see it, and then it's a microcosm of a larger issue. If an employer client wants to do it anyway, woo, that's a tough one. Well, we can run that 7-panel or the 5-panel. They all have THC on them. How do you do it? How do you even buy a 5-panel without THC on it? It's actually not as easy as it seems. You kind of have to pull the panel apart and buy piecemeal. Economically, not great either. But we're seeing more look at it. We're seeing others just throw their hands up and say, okay, we're just going to go to active impairment. If there's any workplace impairment or any issues that we see, then we're just going to go from there. But the fight just simply isn't worth it right now for some folks.
That's exactly what I'm hearing as well, is that it's become too complicated. And the fact that some states will say, yeah, there's a carve out if you're going to be driving a forklift or a truck or something like that, and others don't have that carve out, it's causing confusion. We're all about trying to get uniformity, whatever it is that we're working on, which is becoming increasingly impossible in the hiring process, right? If you look at the different states, this state says you can't look at criminal history, so you can't do a background check. This state says you can't do a credit check. This state says that you can't do anything related to drugs, or you can't ask about their previous salaries, etc. We're running out of things to ask. Right, we're running out of ways to screen people for position. I think the cannabis one is a sticky widget, in part because of what you said, because it's very attractive to the legislators because they're going to get all of this money. But I think also the legislators are not putting in as much thought as they really should about the potential negative externalities, right? Like when you mentioned doctors, that was the first time I had actually thought about that this might actually be something I should worry about. If I go into a hospital in one of these states, is my doctor going to be saying "Chabra" before he puts the IV into my arm? And I'm not pleased about that idea. But overall, you can see the writing on the wall, right? This is not getting smaller, it's getting bigger. And something on the national level is bound to happen when it looks like you've reached the tipping point and more states are there than not. That's when Congress says, well, gee, we should tap into this money too, right?
Okay, so switching gears here, I want to talk a little bit about Rutledge versus PCMA, and if you're seeing any impact on employers and what you guys are seeing from a federal level, because that's been another big one for pharmacy and PBM clients. So
are folks here familiar with the Supreme Court Rutledge case? This was a case a couple years back. The state of Arkansas had imposed a rule essentially saying that a PBM, when they paid a pharmacist, had to at least pay the pharmacist the cost of the drug, because I guess there were instances in which the PBM was paying the pharmacist less than the pharmacist's own acquisition cost. And the implication there was that the big three PBMs that control like 80% of the market were going to put the small independent, community pharmacies out of business, right? And then presumably buy them and open them up. So Supreme Court did side with Arkansas, and this led to a flood of legislation throughout the states. I want to say that right now there's like 100 pieces of legislation that are potentially moving, and 40 that have gotten partway through the process in all the different states, dealing with, well, now we're a state legislature. We didn't think that we could regulate PBMs. Now we think we can. So let's see how far we can push this. And I would categorize the ideas of how they're doing this from the very interesting to the very stupid, right? So starting on the stupid end, there are a number of states that are like, well, gee golly, I want to help pharmacists. So what I'm going to do is to attach a $15 fee to every prescription. Great, this is going to protect the pharmacist. You ask the state legislator, do your voters want to pay $15 additionally every time they fill a prescription? Have you even thought about that? Like, well, no, voters don't have lobbyists. Other states are looking at things like licensure for PBMs. Some states are exploring regulating the pharmacy network, right? They want to say to the plan, you can't, if you have a Caremark plan, you can't only send people to CVS, right? You've got to let them go to whatever pharmacy they want to. Some of them are looking into the length of a prescription. They'll say, well, we only want you to do a 30-day fill. We're not going to allow a 90-day fill. Some of them are saying, we don't like the fact that if you are on an Optum plan and you have a specialty medication, that Optum steers you to their specialty pharmacy. So we're going to try and get in on that. Now we're back to this situation of like, okay, so the Supreme Court said that you can regulate this kind of interaction between the PBM and a pharmacist and the amount of dollars that are flowing there. Supreme Court did not say you can bust into an ERISA plan and tell them what their network needs to look like, what their plan design needs to look like, et cetera. So I wouldn't be surprised if we end up back in the Supreme Court in a couple of years.
And what are you seeing from the worksite health center side?
Yeah, I mean, confusion. Welcome home, Tennessee. Tennessee's variant of the PBM law includes, guess what? Self-funded plans. And if that doesn't sort of cross the line into the ERISA turf, it's hard to see what would. But yes, self-funded plans that are paying for pharmacy costs are saying, gosh, do I have to let any pharmacy in my network? Can I have a differentiated benefit if I have a worksite health center or a worksite pharmacy? And so it's tough. And they want, again, they didn't build these things. They didn't invite us into their house to allow all these restrictions. They want us to be able to service them at a much lower cost. But some of them have most favored nation clauses in there. So if you pay one pharmacy, your worksite health center pharmacy, at cost or a cost plus model, then they're saying, you're forced to accept that reimbursement for all. And so at a PBM level, maybe they can afford it, but self-funded plans can't. And so it's not a good thing.
Yeah, lots of confusion. That's been a big one. I feel like that's like, this has been a tricky one. So one thing I want to ask you, are you seeing issues from a protected health information standpoint? If you've got a clinic, worksite health center, and you've got, your HR department who may want certain information, you've got primary care, you've got occupational health. Are you ever seeing a rub between what HR wants premise to turn over and what premise is actually allowed to turn over? And how do you handle that? Because that's something I see. And I'd love to know, what are the conversations like there? I want some advice here. Like, what are you doing with this?
I mean, Ed can laugh because this is, outside of the pandemic, before the pandemic, this was probably, in the top 3 greatest hits. Yeah. So you have this interaction or this intersection of OG Health, which is the employer provenance. You have primary care, which they can't touch. And then you get this, the mysterious overlay of InfoSec requirements in that if you're going to have a IT system to deliver any of these services, and these are widget contracts, right? These are procurement widget contracts. They're not healthcare focused. And so when we kind of, go in and say, well, we kind of need to carve out our EMR. You can't audit that. Yeah. We can give you some security reports, and we're happy to attest to anything that you need us to attest to on the security side, but we can't let you in because you don't need access to it. I mean, the most compelling discussion point that I kind of resonates with employers, particularly when you get to their lawyers, unfortunately, sometimes it gets to that, is, look, there's information in those files you don't want to know. You do not want to know if they have some behavioral health history. You don't want to know if they have substance abuse, because then that's a blank check for those employees to write ADA claims. And so there are things you want to know and things you need to know, but there are lots of things you don't. And so let's sort of acknowledge, how that's maintained and kept. Now, part of the challenge, if you do OG Health and primary care, is how you delineate within systems. And just because you're not billing doesn't mean you're not a HIPAA entity. Yep. Because if you have anybody else in that legal structure anywhere billing any commercial plan, they fall under covered entity. So it's best to just, be careful, be open and honest about expectations about what you're going to be able to get. Some things that seem fairly innocuous. A visit report. Can I get a report of who went to the clinic today? They said they were out sick. I need to validate that they came into the clinic. They said they came into the clinic. So there are certain lots of restrictions. The best way as an operator and to keep things compliant, and yes, privacy and compliance rolls up to me too, is authorization. You have to get patients' authorizations. It feels very bureaucratic and it's not fun for anybody, but hey, you presented for this occupational, and particularly in light of, I'll ramble a little bit, in light of interoperability and the ability to get primary care records from across the community, we're an Epic shop, right? So we can see a lot of community records. Epic has a wonderful tool that you can get a very holistic view of that patient's history. It's very compelling. It's very clinically sound. But if you're in for an occupational health visit or DOT and you click on the wrong button, you're going to see stuff you probably shouldn't have seen. And so constantly engaging the patient to authorize or not, I mean, they can decline, but it just keeps it at the forefront that they are allowing you to take a peek at their holistic record. So.
I would make a bold prediction, which is that for self-insured plans, there will be new cybersecurity rules that are going to come out just based on conversations with DOL.
Well, I would say DOL has their new cybersecurity guidance that came out in April of, was it last year too? So that's been a big one for the plans already, but it's guidance.
Which right now that guidance, it doesn't actually say the word like health plan in there, right? And so a lot of people think that guidance only applies to retirement plans. Yep. But that's just one piece, right? We're already following HIPAA. There are already rules from IRS on how we handle Social Security numbers, and there are rules related to ADA and the EEOC's rules on GINA. So are they going to just pile something new on top of this, or are they going to try to coordinate with what we're already doing? And that's, I think, a big question, and they haven't answered yet.
Yeah, and for anyone out there, if you've not looked at the DOL's cybersecurity guidance, it's actually, I can't believe I'm saying this, it's well written, it's concise. So if you're already following HIPAA, you're probably already complying with it. And again, it's guidance, but it is a really good tool. So something we always tell our clients to look at. Okay, so I'm curious, what keeps you up at night as the general counsel of a national healthcare company in almost all 50 states? What's your risk management thing that just like you think about?
So, keeping awake indicates I go to sleep. Employment, I think there's a lot of disgruntlement in the workforce. So employment claims, yeah, they happen, but I think there's a sense of that there's a little bit. I think the plaintiff's bar is a little more aggressive in pursuing some of that. Believe it or not, medical malpractice is not at the top of it. It really is the licensure and compliance with data regulations. So we're partnering with a lot of our clients that are asking about submitting machine readable files, right? Part of the Affordable Care Act included that this requirement to submit machine readable files. Well, unless you're fee for service and have a fee schedule, the machine readable file for a cost plus or a PMPM model or anything that has any value performance guarantees associated with it, a visit isn't a visit, and you can't put a value on it. So lots of those conversations, lots of ensuring that people have the data they need to be compliant across different industries. Federal contractors have different requirements than banks that have different requirements than other security operators.
Larry, we've got about 5 minutes left. So I have, a whole list of questions, but I love questions from the audience, I think would be the best. So.
First one, James, could you speak to the FTC investigation into PBMs or the CCA legislation around fiduciary responsibilities?
Yeah, so the FTC had debated whether or not they were going to investigate pharmacy benefit managers, and they decided against it. This was an effort that was mostly driven by the independent pharmacists, who again, they feel like victimized by the big PBMs. But when an additional commissioner was confirmed by the Senate, they voted again, and they did decide to investigate the PBMs. And they sent a extremely long, extremely detailed letter to, I believe, the 8 biggest PBMs that asked about virtually every aspect of the business. It asked about all the contracts that they have between the PBM and the pharma companies. It asked about the steerage to their own in-house pharmacies versus, the independent guys. It asked about the profits that they're making. The information that's likely to be disclosed will probably be explosive, but it'll also probably not be for a long time, many months there. And then also, the Consolidated Appropriations Act has now hit the implementation phase on all the transparency requirements. And that, of course, kicks in some new fiduciary liabilities for plan sponsors, and in some cases for their partners who are offering care and vendor services, et cetera. A whole lot of new stuff needs to be disclosed, but with great knowledge comes great responsibility in this case, right? So as an ERISA fiduciary, you are responsible to not pay unreasonable fees. And if it turns out that the plan's been on autopilot, just listening to whatever your consultant or broker told you to do, going with vendors without having a process in place to do a lot of comparisons and benchmarking, you very well might find yourself the victim of either a lawsuit from your plan beneficiaries, or DOL might pay you a visit.
Will, does a premise partner with any colleges, universities to treat students? And if so, how do you handle schools operating under FERPA versus HIPAA and expectations that they should have access to student health care?
We have one that treats a limited subset of students, and it's really in an athletic capacity. So we don't have to bump up against that as much. Have you seen it? You probably.
Yeah, so HIPAA actually, I will double check this, don't quote me, and it carves out FERPA records. And so if you're treating students at a college or university, FERPA is going to be basically the guiding tool if they're actually student records. But it gets a little tricky sometimes when there's also primary care and other things going on there. So it's definitely one you need to watch out for. And then you overlay on that too, sometimes issues with, state law privacy, mental health records, EAP, and issues with minors, frankly, if you have that. So it's a nice conundrum.
Other questions? Anyone? What about some new EEOC rulings? Question back there. We're about out of time.
Pregnancies are unplanned, then we owe it to our workers to help them get birth control methods that are really reliable. So if we're not offering GYN and access to birth control, long-acting reversible methods, then we're failing our workers. So it's not a question, it's a comment, and it's a challenge. If you're not providing GYN care for your workers, shame on you, you should be.
Yeah, and actually one thing we've talked about too, thank you. Yeah, lots of agreement up here, at least for me personally, but is that you're going to see regulation of birth control too. So I think that's something that is definitely going to be around the bend here for most states. I think we're out of time, but if you have other questions, we'll be around during the break, so feel free to stop by.
All right, so let's thank Will, Stephanie, and James for the good stuff.